Moss Adams is pleased to present another in our ongoing series of continuing professional education webcasts. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize both how you view our presentation and how you interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. For example, you can click the file folder icon to download the group attendance sheet and a PDF copy of today's slides. You can ask our presenter questions during the webcast by clicking Q&A in the bottom left-hand portion of the icon bar and typing in your question. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. We'll ask polling questions throughout today's presentation. Per the National Association of State Boards of Accountancy Webcast CPE standards, CPE credit will be awarded based on your participation in these polls. To respond to a poll, click the button next to your answer. If you're attending this webcast in a group, in order to receive CPE credit, you must complete our attendance sheet, available in the file folder icon at the bottom of your screen. Please have all group members sign the sheet, and please remit only one sheet per group. Also note, today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. CPE credit can be awarded only to participants registered as themselves and is not available to participants who view the on-demand version. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon to open a PDF file you can save to your computer. We'll email a copy of your PDF certificate in 2 weeks if you can't download it today. As a reminder, the presentation you're about to see is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
Good morning and welcome to today's webcast, 2016 Medicare Regulatory Update for Hospitals. I'm happy to introduce today's speakers joining us from Moss Adams Healthcare Consulting Group, Glenn Bunting, Director, and Paul Holden, Senior Manager. Glenn, I'll turn the line over to you to get us started.
Okay, thank you, Emily. Today we will be covering the topics that you see on your screen, wage index deadlines, which should be among the forefront of on everybody's mind these days. We will also cover the inpatient prospective payment system final updates for federal fiscal year 2017. Those officially came out on August 22nd, last month. We'll cover DISH, uncompensated care payments, medical education, which will be handled by my colleague Paul Holden. And there's some important news there for teaching hospitals that he will address. Readmission policies, a value-based purchasing program, and then from there we'll go into the outpatient prospective payment system, the proposed rule which came out in July of 2016, and we'll touch briefly on the Medicare physician fee schedule proposed updates, which also came out in July of 2016. So first, wage index deadlines. The wage index cycle covers basically a whole year period. It starts in this year it started May 16th, 2016, with the release of the public use file for federal fiscal year 2018. And in that file, it contained fiscal year 2014 worksheet S3 wage data files and also 2013 occupational mix data. We have a September 2nd deadline, which just passed, which allowed hospitals to request revisions to wage index and their occupational mix data. The next deadline that's up on the block is November 4th, and that is the deadline for your MAC to notify your state hospital association of any hospital that did not respond to wage index requests, queries, that sort of thing. And then member hospitals that fail to respond to the MAC inquiries can result in a lowering of the area's wage index value. November 15th is the deadline for the MACs this year to complete all their desk reviews of all the submitted revisions. And then we move into the end of January when we have the release of the fiscal year 2018 wage index PUF file, and that'll be on CMS's website. at that point in time, it's critical that you review your wage index data and make sure that it is what you expect it to be. If it isn't, you have an opportunity in February to reply back to the MAC and get that data corrected. At that point, the MAC won't be accepting any new data, but if they have adjustments to your filed data or your data corrections that you submitted on or before September 2nd, that's the time period to address any deficiencies in your data. There's also an appeal period, which happens in the spring, and then eventually in the late spring, sometime around May, the final PUF data is released again. And then there can be a little bit of modification that happens in the summer, but only under limited circumstances. So where are we in this cycle, and why is it important to you? Currently, we're in the period between September 2nd and November 4th, and that's the time when the MAC starts their review of the data. And if experience is any barometer, you basically will have a short time frame to respond to the MAC and their data questions and inquiries. It's critical that you respond timely to the MAC so that you can get your data included in the wage index PUF file that is released at the end of January of next year. So the question really gets down for some, why should we care? And the answer really is pretty simple. Your wage index data directly influences at least 90% of your Medicare reimbursement. Hospital wage index values impact the development of the wage index factor for psychiatric services, rehabilitation services, SNFs, home health, hospice, and others which don't have rural floor protections. So for all of these sub-providers, the data that you report annually for your hospital influences those sub-provider wage index factors. So if you're from a hospital that receives the rural floor in your state, that rural floor protection only applies to your inpatient, acute care, and outpatient services. So as an example, the rural floor is very prevalent in the state of California, where we have 9 hospitals that control the wage index factor for hundreds of hospitals located in the Southern California and San Diego regions. What we find there is that there's a large disparity between Southern California hospital inpatient and outpatient wage index factors and sub-providers of those same facilities. So as an example, when I look at the Anaheim area, I see that the wage index factor that will begin on October 1st, 2017 is 1.2781. Yet the psychiatric and rehab wage index factor for that same period will be 1.1794. Riverside, same situation. 1.2781 is their inpatient and outpatient wage index factor, but for their psych and rehab facilities, they're going to get a wage index factor of 1.1684. And then finally, San Diego, again, they get the rural floor, 1.2781, but their psych and rehab wage index factors are 1.2060. There are a handful of states where the rural floor does control the wage index factor. 2 of those states are Alaska and Massachusetts, where in Alaska you have 2 hospitals that basically control the wage index factor for the entire state. In Massachusetts, there's 1 hospital. In terms of the wage index factors and the data that's been released, there's a bit of good news and a bit of bad news, or maybe I should say not so good news. In terms of good news, I note that the average hourly wage for hospitals located in Los Angeles and Long Beach is moving in the upward direction and is within $1.20 of exceeding the rural floor in California. So that's good. They're getting closer to basically controlling their own wage index factor destiny. And so the hospitals in that area look to be doing a good job in terms of improving their average hourly wage in their Medicare cost reports. And they're within striking distance of exceeding the rural floor. In terms of the not so good news, the California rural floor, for the first time in a long time, as far as I can remember, has actually experienced a decrease this year. So starting October 1st, 2016, the wage index factor for for the rural hospitals and the hospitals in Southern California and San Diego, as part of my example, it's going to decrease from 1.3012 to the 1.2781 factor that I mentioned before. So this is going to negatively increase the Medicare inpatient payment for hospitals in California that are subject to the rural floor. And in short, it's a huge haircut in reimbursement. Some have asked me, why did this happen? And the answer lies in part with what's going on with the national average hourly wage, which I note increased from 40.26, that's $40.26 per hour, to 41.16, which is a 2.25% increase in a one-year period. So if your respective individual hospital's average hourly wage did not increase by at least 2.25% in that one-year period, odds are that you will also experience a decrease in your wage index factor. For the California rural hospitals, their collective average hourly wage increased only 5 cents from one year to the next. So while the numerator in this equation was basically flat, the denominator increased significantly, causing the wage index factor to drop for these hospitals in this area. We wanted to spend a little bit of time on the wage index geographic reclassification topic. First of all, for some, they might ask, what is a geo reclass? In short, it's an election one can make to obtain a wage index factor from a neighboring core-based statistical area that is likely more favorable than your own. Typically, although it's not in all cases, you must meet a wage test and a proximity criteria. But reclassifications are real good, because once they're approved, they're good for a 3-year period. On the downside, when you are approved, CMS and the MACs do not publish reminders to hospitals about these geo reclasses, so you have to have a good internal mechanism for keeping track of these approvals. The deadline for seeking a geographic reclass just passed us. It was September 1st. Seems to always be the first working day of September. This also marks the deadline for canceling a previous wage index reclassification withdrawal or termination. Note, it's not the final deadline, but it is the first deadline. The geographic reclassifications that were submitted by September 1st, 2016, if approved, will be effective on October 1st, 2017, next year. There are currently 817 hospitals in reclass status for federal fiscal year 2017, and of these, 57 hospitals are reclassified to rural areas. A bit of a change in the process, and this was in the final rule, is how these reclassifications are to be handled. In the past, you would send packets of information to CMS and to the MGCRB. Going forward, they changed that process a little bit. I guess CMS didn't want to receive all kinds of paper, so the CMS now requests that you submit your reclassifications electronically through the website or the web address that's on the screen. The MGCRB still requires paper copies to be sent. Occupational mix is basically an adjustment that is applied to your average hourly wage in your wage index factor calculation. It measures basically the amount of nursing care provided by your facility to the national average. So if your average hourly nursing care ratio is higher than the national average, you are going to receive a negative adjustment, and that negative adjustment will be applied to your hospital's average hourly wage. This all happens outside of the cost reporting process, but there are occupational mix PUF files that have this information, so you can gauge and analyze and see where you are in this process. If your average hourly nursing care ratio is less than the national average, you're going to receive a positive adjustment, and that'll be applied again to your average hourly wage. A couple of facts here is the occupational mix values change slightly each year, and every 3 years they reset. The next survey is expected to be due July 1st of 2017, and this survey is expected to be based upon your payroll data for calendar year 2016. We always recommend that your occupational mix survey information be reviewed by an expert or somebody outside of your organization or somebody that you really trust, because before it's, and that's, get it reviewed before you submit it to the MAC, because the fact is this data has a 3-year impact on the development of future wage index factors. The largest changes to the filed surveys typically happen in the first year. So you submit the data, and then right away you realize something's wrong and you get it changed. And then maybe you're good for years 2 and 3. The smallest changes are always in year 3. So it usually takes about 3 years before everything kind of settles out, and then they reset and you submit new survey data. In my experience, most hospitals have an occupational mix value that's in the 95 to 102% range. So if you're on the low end of this range, it might be worthwhile to revisit your data again. We have one hospital in the state of Oregon, and it's a rural hospital, but it maintains an occupational mix value of around 112%. So at the end of the day, their average hourly wage is increased by 112%, and because they're a rural hospital in Oregon, it basically has the effect of lifting up all of the rural hospitals in Oregon and giving them a higher wage index value. The national average nursing category on the slide, the $32 and I'll round it 86 cents, is the key number that you'll want to keep track of when you look at the occupational mix data. A couple of wage index facts. We have 407 urban CBSAs across the country. And of those, or I should say, in addition, there's another 47 rural CBSAs. That's one for every state. We know that the states of Delaware, New Jersey, Rhode Island, all are urban. They have no rural CBSA, and that's just due to the makeup of the demographics in those states. They have an imputed rural floor that has been extended for 1 year through September 30th, 2017. I expect that'll continue. CMS is always exploring for potential wage index reforms. The current system, as I explained with the rural floor, sometimes creates inequities, but really to take any action on reform, that's going to require Congress to take some action. Also, there's what's called an out-migration adjustment, and this is an adjustment that's applied just to certain hospitals. It is listed in the wage index tables, so you should go look at your wage index tables to see if it's applicable. 293 hospitals across the nation receive it. However, if you receive a geographic reclassification, you will receive that and you will not receive the out-migration. Again, the next occupational mix survey is July 2017. There was a change a few years ago regarding how pension costs were to be handled. And if I go back a few years, there was a large change in terms of pension costs are to be reported, and this would be pension costs pursuant to qualified defined benefit plans. Those pension costs are to be reflected as your contributions to the plan. So that's many years ago. And then what they did was they made a change where they used what is called a 3-year rolling average. And you would always calculate these costs using the prior year contribution and the future year contribution. But when you're filing a cost report, that created a problem because how can you know what your next future year contribution is going to be? So last year, CMS implemented a change to pension where they changed the 3-year average, contribution average, to the base year, which would be your current year, plus the 2 prior years. So for the upcoming wage index review, which the MAC is getting ready to do right now, they're going to be looking at your pension costs. If you are a September or a December year end, they're going to be looking at your cost reports from 2012, 13, and 14. And if you are a March or June year end, they're going to be looking at 2013, 14, and 15. Questions popped up about what is a CBSA. A CBSA, the definition is core-based statistical area, and it can consist of hospitals in, I'll say, one county or multiple counties that are contiguous. So that's what a CBSA is. There's some talk in the Federal Register about wage index and the overhead treatment or the overhead cost treatment. And right now, CMS didn't take any action, but they're soliciting feedback on proposed changes to Worksheet S3 Part 4. And some of these changes include new methods of allocating wage-related costs to excluded areas, and there's also some feedback on treatment of home office costs that are being added in via line 14 of the worksheets. If the home office allocations include services beyond A&G costs, they need to be assigned to corresponding lines on S3 Part 2. When we look at this has the effect of possibly lowering average hourly wages in the wage index data, which is not a good thing. So this is just something to kind of, I just wanted to kind of bring to your attention and keep your eye on, and we'll monitor it and see where it goes. One new item that has come up, and this is a new development this year, is our hospitals that have reclassified from urban to rural, and whether they are eligible for what's called stacking. Stacking is now allowed. Historically, hospitals were prohibited from pursuing a geo-reclass if they elected to be reclassified from an urban area to a rural area for purposes such as sole community status, 340B, and others. And what CMS did was they viewed this as a double reclassification. And it's just not allowed in court. It wasn't allowed in accordance with geo-reclass instructions. But there was a development, actually 2 developments really. There were 2 federal district court decisions in 2 separate jurisdictions which concluded CMS did not have the authority to prohibit reclassified hospitals from seeking a geo-reclass. So CMS has relented on their positions, and hospitals are now allowed to pursue stacking. The wrinkle in this is that hospitals can pursue an urban to rural reclass at any point in time during the year. It can be effective no later than 60 days after CMS receives receipt of the application. It can apply at any time, like I said. And so what CMS is concerned about is hospitals that do reclassify, how are they going to be incorporated and when are they going to be incorporated into the development of the wage index factors. So what CMS decided to do is they're setting in what's called a locked-in date for a list of hospitals reclassified from urban to rural status for rate-setting purposes. And the locked-in date is the 2nd Monday in June of each year. So depending on your status on that date, that'll dictate whether you're going to be reflected as an urban or a rural hospital for wage index purposes. And what it does, and it's probably a good thing, is it allows more transparency into how the wage index factors and the budget neutrality factors and that sort of thing are being utilized in the rate setting process. So at this point, we come to our first poll question, and I'll turn it over to Emily.
All right. First question today is, do you participate in the Medicare wage index correction cycle each year? And if so, what is your primary area of focus? And your options are, yes, and my primary area of focus is paid hours. Yes, my primary area of focus is wage-related costs. Or my primary area of focus is contract labor. And finally, no, I do not routinely participate in the annual Medicare wage index correction cycle. Now I'll give you a few moments to respond. To participate in the polls, please click the button next to the answer you choose and hit submit. And let's take a look at the results.
The results, to me, seem a little bit surprising. I guess we may have a lot of hospitals on the line that might have critical access status or something along those lines. Hopefully, the no, I do not routinely participate in the annual Medicare wage index correction cycle is not something that's indicative of a large majority of PPS hospitals. That wouldn't be good. Of the other two, or of the other three responses, where it says yes, the primary area of focus is contract labor. That's what I would expect. That's an area where it's hard to get all the contract labor recorded, or I should say reported, in the cost report at the time of filing. So at this point, I'm going to turn over the presentation to Paul.
Thanks, Glenn. Good morning to everyone on the line. What we're going to do with the presentation now is we're going to transition from the wage index element of the inpatient rule to the actual rate setting piece, and this is where we start before we geographically adjust our labor portion for the wage index. So as we can see in this year's final 2017 rule, the base payment rate for those CBSAs whose wage index value is greater than 1, we have increased the base payment rate just about $58, almost $59, and you can see that the base payment rate for those CBSAs where the wage index value is greater than 1 or less than 1, the total base payment rate is the same. It's just the distribution between the labor and non-labor related portion. Now, to arrive at our base payment rate for the labor and non-labor related portion, we refer to this slide as the Medicare giveth, Medicare taketh away slide. And as you can see, the base payment rate each year is starting at the prior year base payment rate with previous adjustments backed out, and then we start to incorporate the current year reductions. So we always update our base payment rate for the market basket each year. CMS uses a Laspers type market basket adjustment, which folks will be familiar with, very similar to a consumer price index, measuring a basket of core services over a period of time and how the cost of those services expands and contracts. Then we back out things such as recalibrations, budget neutralities. We can also see here that there's a significant reduction for the documentation and coding recoupment here of 8.82%. That originated when CMS transitioned from the historical DRG system to the MS-DRG system. They felt that the enhanced payment that hospitals were receiving was not indicative of the actual acuity of the patient population itself, and so they started to take away payment from the DRG to account for that offset. This year, they anticipate that they will reach their full $11 billion take-back. And so we are anticipating that going forward, that documentation and coding adjustment will either be eliminated and or significantly reduced. The other item that we see on here relates to the 2 midnight rule, which I will talk about in a minute, but that's actually being added back this year at 0.6%. In terms of the market basket adjustment itself, very important now that folks are reaching stage 1, stage 2, and eventually stage 3 EHR, that also being a meaningful user of EHR and submitting quality data each year is extremely important. As you can see, if you are doing both, you're receiving the full market basket update of 1.65%. If you are submitting neither, you have a reduction of 1.05%. That's a pretty big swing between fully participating and not participating at all. So it certainly is imperative for those folks who have their EHR systems up and running, they have their quality data in hand, to get that over to CMS so you are getting your full DRG-based payment rate. The 2 midnight rule. This has been a hot topic of conversation for folks for several years. In the final rule this year, as outlined in the proposed rule as well, CMS has decided to go back and eliminate the 0.2% reduction. This originated with a court case, Shands-Jacksonville Medical Center versus Burwell. The court decided to remand this decision back to the CMS, or the Secretary of Health and Human Services, and deemed it a procedural error. And this is very important for those folks who follow CMS policy and rulemaking. They deemed it a procedural error because there were quite a few court cases out there, mainly spearheaded by the American Hospital Association and others. So by deeming it a procedural error, they did not have to settle a bunch of court cases. They could go back and basically say, CMS, please revise your position. We're not going to create a precedent, and you can correct things going forward. CMS only has the ability through the Social Security Act to make changes prospectively. That originated back in 1983 when they created the DRG payment system. They made the decision to only correct things prospectively, so they had to create things like recovery audit contractors and zone program integrity contractors and others who could go back retrospectively and recoup funds. So this 2 midnight rule is a perfect example of how CMS can make a change and make the change going into the future. The problem is that even though they are adding back 0.6% to account for 3 years of 0.2% reduction, will the hospital's future activity be enough to recoup what was taken away in the past? So an important point for folks to be aware of. Each year in the rule, we have our national average cost to charge ratios. We won't spend a tremendous amount of time on this slide, but you can see this is a comparison of last year's final 2016 cost to charge ratio and then to the 2017 cost to charge ratios. These cost to charge ratios are used for the behind the scenes rate setting. For those folks who may have attended some of our presentations in the past on this, these 19 common cost to charge ratios are used to set the DRG weighting factors. So for instance, with a cardiovascular procedure, this is the information that they use along with MedPAR claims data to determine that the weight for that cardiovascular procedure should be 10.6 as opposed to 8.7. This is an interesting slide that we've inserted this year. This was information that was presented in a newsletter from Becker's Hospital Review. We thought it would be interesting to put in when we're talking about the inpatient rule, because these are the 20 most costly inpatient conditions nationwide, sorted from highest to lowest, and this is actual hospital cost, not reimbursement, and it's only the brick and mortar hospital side of the equation. It does not include the physician service. So as we can see, septicemia has been quite a big topic for folks in the last couple of years, and we can see why. It is a big cost area for hospitals. Osteoarthritis in there, live birth, and then you can see kind of moving down the list. So it's interesting when you look at these costly conditions compared to where the utilization is in your facility, you can kind of see where some of the cost drivers are by service area. I wanted to spend a moment on this particular slide. This is good information from the Kaiser Family Foundation. This actually shows Medicare benefit payments by type. Now, this is from 2015 data. And the reason why I've highlighted Medicare Advantage is that what we're seeing nationwide is that those baby boomers and others who are coming onto the Medicare program are opting for Part C coverage because it looks and feels very similar to the commercial insurance that they had when they were previously employed. Now, what's interesting is that all of the rulemaking that CMS does, when they go in and they're running MedPAR claims data and they're looking at other things, they're generally focused on Medicare Part A activity, because Medicare Part A activity is what ultimately ends up with a you owe us, we owe you number in the Medicare cost report. So those cost to charge ratios that we displayed earlier, those are Medicare Part A, quote unquote, focused cost to charge ratios. And so over time, as Part C plans become more prevalent, as that activity becomes greater and greater, we anticipate that we may see CMS really start to account for more of that plan data in some way, shape, or form, because that really is a larger bulk of the utilization. The scary part of this number is not so much for the DRG facilities, although they do have their payer contracting concerns, but for the Medicare activity in critical access hospitals. Medicare Part A is the only element that is cost-based settling for those facilities. So if you have greater and greater Part C utilization, you're not getting cost-based reimbursement for the hospital side of that service. You are getting a similar interim payment rate, but at the end of the day, you're not settling to 101% of cost. So we've talked to quite a bit of folks about that over the past year, and it's something to be aware of as you're looking out and observing your payer mix month in and month out. So these next few slides we'll go through fairly quickly so that Glenn can dive back into disproportionate share and uncompensated care. Our outlier, our fixed cost threshold, continues to creep up. What that means is that each year it's becoming a little bit harder and harder for facilities to get over that hurdle when you have a high-cost case. So something to be aware of as you're doing your planning each year. Capital costs. One thing I want to highlight with this slide is that it's very important for facilities to accurately complete the Medicare cost report. There's several sections in the cost report that call out capital costs. The first one being Worksheet A7, the second one being Worksheet B Part 2, Column 0, which are your capital-related costs that are directly assigned to a particular cost center, those specifically being lease and rental expense. You want to make sure whether you've purchased a piece of equipment or you own a building or you're leasing that MRI or you're leasing particular office space to provide patient care, that you are telling Medicare the most accurate and advantageous story possible so that when they go through and do their algorithm calculations on capital costs, that when that capital rate is updated each year, that it's as beneficial as possible. Sole community hospitals, similar to DRG facilities, they are going to start with their hospital-specific payment rate. They are going to receive a rate update, and then they are also going to have certain elements taken away as they either report quality data or are meaningfully using EHR. For those sole community hospitals that are in a rural area, you will continue to receive your 7.1% add-on to your APC payments. And then I also wanted to highlight our low volume adjustment here for those folks who qualify. Hopefully you got your re-up application to your Medicare Administrative Contractor, which is, as Glenn mentioned earlier, the MAC. That's what MAC stands for. Hopefully you got your MAC application in by September 1st. This continues to be in effect. Currently, it's been extended through September 30th of 17. What we are seeing is that this is occurring in off-cycle rulemaking, meaning that it doesn't appear as much in the Federal Register as it is as a rider to other legislation that continues to extend this. And it's a big benefit. I mean, we have some facilities here in the state of Oregon and Washington where this specific adjustment is anywhere from $500,000 to $800,000 a year in additional reimbursement. So very important that if you're eligible, you continue to submit your application for the LVA. And with that, I will turn it over to Emily for our second polling question.
Great. Thank you, Paul. Our next question is, in regard to your facility's payer mix, is Medicare Part C outpacing Medicare Part A? Yes, no, depends on the year, or I'm unsure. And as a reminder, if you'd like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. And I'll give you a few more moments here. And we'll take a look at the results.
Very good. Well, thanks to all who participated So this is very interesting, and this is actually just about where I would expect it to be. Certainly there are folks on the line who don't look at this on a daily, monthly, or yearly basis. Depends on the year is a very interesting response. And the no is an important response because this really is regionally specific. There are certainly areas of the West Coast and elsewhere in the country where Part C plans are more prevalent than others. So you're certainly going to see those folks still continue to sign up for traditional Part A coverage when they become eligible. And with that, I'm going to pass it back to Glenn and to start talking about DISH and uncompensated care. Glenn? Glenn may be on mute at this point.
Sorry, thanks, Paul. DISH, uncompensated care. There's no change to the eligibility requirements for DISH or uncompensated care for federal fiscal year 17. Hospitals that are in Maryland or hospitals in rural community hospital demonstration programs are ineligible for DISH. There's just a handful of these hospitals that participate in the rural demonstration programs, but once those demonstration programs end, the hospitals are eligible to participate. CMS has determined in federal fiscal year 17 that gross DISH payments are estimated at $14.397 billion in the final rule, and that's compared to $13.732 billion last year. And that's roughly a 4.84% increase in the DISH payment pool. Once that payment pool is established, CMS then makes a calculation, and they apply 25% of that payment pool is going to be reimbursed to hospitals through the old traditional DISH calculation, which uses a hospital's individual SSI ratio and Medicaid patient day ratio. The remaining 75% of the payment pool goes through a three-step process, and it's referred to as factors 1, 2, and 3. So factor 1 is developed basically mathematically. It's 75% of your DISH payment pool, which turns out to be this year $10.797 billion. Factor 2 is developed based upon a mathematical formula. As you can see on the slide, it's very complicated, but basically what factor 2 does is it measures the amount of uninsured patient population compared to a baseline. Last year, the uninsured patient population was determined to be 11%. This year, the CBO is saying for fiscal year 2017, the uninsured population is now 10%. So as the uninsured population decreases, what happens in the payment formula factor 2 is it results in a negative it has a negative impact to your DISH payments. So as the uninsured go down, your DISH payments go down. So once you take factor 1 and you apply the formula to factor 2, you're left with $5.977 billion. At that point, the payment pool, the $5.977 billion, is distributed to hospitals through factor 3, and this is probably the area that's most controversial in the final rule. Up to this point, the distribution of the DISH payment pool has been based on a hospital's SSI ratio and Medicaid patient day ratio, and that's derived from a single year cost report information. CMS has decided to make a change beginning this cycle. The factor 3 distribution is now going to be based off of a 3-year average, and that's a 3-year average of your SSI ratio as shown on the screen and a 3-year average of your Medicaid patient days. We note that there are 2,432 hospitals that are projected by CMS to receive DISH and uncompensated care in 2017, and that's per their DISH supplemental file list. but not included as expected, and consistently they have not included sole community facilities. One additional change that is not on the screen here is hospitals that were located in Puerto Rico have complained that they're being disadvantaged because they haven't been eligible for the uncompensated care pool payments in the past. And so CMS has listened to the folks from these hospitals, and this year they decided to include Puerto Rico hospitals in the uncompensated care pool. Part of the problem has been the hospitals in Puerto Rico don't have SSI data. And so CMS established a 14% proxy for their SSI ratio. And the long and the short of this is that these hospitals in Puerto Rico are going to now receive disproportionate share uncompensated care payments, but it's not going to have a material effect on everybody. So there's more coverage and a little bit less for everybody else. We have a slide here that shows the impact of uncompensated care payments for this next year. And overall, we're looking at a $416 million decrease in payments for all states. It's kind of interesting to see, California is experiencing a 5% decrease from the prior year. Oregon is very close, 4.93%. Washington, 6.36%. So all these hospitals that receive disproportionate share and uncompensated care payments are all expected to receive less money in the coming year. One of the major changes that was proposed and then CMS backed off on it was the use of Worksheet S10 data in the distribution, the Factor 3 distribution of the DISH uncompensated care payments. CMS decided that they were going to move forward with S10, and that was laid out in the proposed rule that came out, I believe, at the end of April of this year. And then in August, in the final rule, they decided to back off. They want to give hospitals more time. The primary reason they backed off is there was a lot of concern, and hospitals voiced a lot of opinions, actually some positive and some negative, about moving forward with S10. But at the end of the day, the CMS pulled this off the table, and they did it because there was just a lot of public input. They determined there's a lack of uniformity on how S10 is being reported. They determined that cost report instructions will need to be revised. And they needed, the one that surprised me most is CMS stated they needed to decide how they were going to audit S10. I don't know what has happened in the last few years internally at CMS, but one would think that question would have been resolved by now, but apparently it's still a question. What CMS did say is that they're going to move forward toward an uncompensated care model using Worksheet S10 data by federal fiscal year 2021. And they did state that it could happen possibly prior to that date. So it could happen as soon as next year, or it could happen in 3 years. So the moral of that story is don't wait any longer. If you're unsure about your Worksheet S10 data, you need to be looking at it now and trying to improve it. And you need to do it before CMS makes the official announcement that they're going to be using that data to distribute the uncompensated care pool. We're not certain when the change is coming, but we do know that the change is coming. One other note on DISH SSI realignments. CMS issues SSI ratios annually every year. It's a good practice to go out and look at your ratios and compare them to the prior year. If your ratios are increasing from year to year, you might benefit from a realignment, which is taking your SSI ratios that are developed on a federal fiscal year and shifting the data to a cost reporting year. You'd want to do some analysis on that before you make an election to do it. Once you make an election to do it, you're committed to that for that request. SSI realignment is not something that continues. Once you elect it, it continues forever. It's handled on a request by request basis. You can pick which cost reporting years you want to realign and which ones you don't. but it's just something that I wanted to give everybody kind of a heads up on. And with that, we come to our third polling question.
All right. Our third question is, how confident are you that your Worksheet S10 information in your filed Medicare cost report is accurately stated and compliant with current Medicare cost reporting instructions? Very confident, somewhat confident, uncertain or not applicable, or not confident. We need to review this area. And for those of you that would like a copy of today's slide deck, you can download them from the folder that says Slide Deck and Handouts at the bottom of your screen. We will also be sending the slides via email after the webcast. And let's take a look at our results.
I think the results are pretty consistent with the comments that were made in the final rule, and that would be consistent with why CMS decided to extend their use of the S10 data. So with that, I'll turn it back to Paul.
Thanks, Glenn. Well, in our remaining 9 or 10 minutes together, I wanted to make the group aware of a handful of peripheral items that are still important, but certainly wage index and S10. As Glenn pointed out, once we set that base payment rate, the geographic adjustment of the labor portion of your payment is significant to facilities. You know, every year when you're preparing the cost report, the wage index survey is a key element of that. Even though you have opportunities to expand on that information during the correction cycle, more and more facilities are really trying to get as much information into that filed cost report as possible. And certainly S10 going forward is going to be a make or break for some facilities. To reiterate a couple of other points within the inpatient rule, I wanted to highlight 2 items with medical education. One, most facilities are doing a great job with shadow billing their Part C claims if you have residents rotating through your facility. As a reminder, sole community hospitals that have that are now paid operating IME by the Medicare contractor. The other piece of this is in the final rule, Section 5506 of the Affordable Care Act allowed the opportunity for closed teaching programs to have their FTE slots redistributed to those facilities that are seeking to expand their programs. CMS gives preferential treatment to contiguous core-based statistical areas that are near a facility that recently closed their program. And kind of that's first preference. The second preference then goes to rural facilities. So just to be aware of that, in the rule there is some more information on that, and we can certainly assist if you would like further information on that as well. Focused on quality, CMS continues to put information in the rule regarding the readmission reduction program, value-based purchasing, hospital-acquired conditions. One additional condition that they're looking at for readmissions are coronary artery bypass grafts. This has been a procedure where CMS has not addressed cabbage for a while. They considered it a procedure where the likelihood that somebody was going to come back within 30 days was pretty high and usually not at fault on the hospital's part, but they're finding more and more as technology and clinical integration come together that they want to start looking at that as well. The readmission calculation, CMS goes through the detail in the rule. Hospitals can also go and purchase that information and do quality assessments on their own, and we've given you a link here. It is interesting that over the past 5 or 6 years, readmission rates are going down. Facilities are highly focused on quality, utilization review, medication reconciliation. All of those things are starting to come closer and closer together, and we are seeing improvements with readmits. Value-based purchasing, just to make folks aware, there is quite a bit of detail in the tables to the rule on value-based purchasing, giving individual scores. We're also seeing quite a few hospital associations start to aggregate VBP data for facilities in their state. As a reminder, with value-based purchasing, This is an area where CMS uses what are known as topped-out measures. CMS puts the conditions into the value-based purchasing program. When they've collected enough data, they basically take those off the table and start to add more criteria for facilities to meet. The challenge with value-based purchasing, as most folks are aware, is it's made up of both clinical measures as well as patient satisfaction. So your clinicians and your discharge planners can do a great job, but if the patient has a bad experience with the business office, it may throw off your HCAP score. So what's really interesting about value-based purchasing is it includes the whole life cycle of the patient's experience in your hospital, all the way from pre-scheduling a surgery until the last payment hits your bank account. So really something to be aware of with value-based purchasing. So in our last few minutes together, I wanted to quickly cover some highlights from the outpatient perspective payment proposed rule, as well as the physician fee schedule. OPPS paid on a conversion factor. Our final conversion factor here our proposed conversion factor for 2017 right now sits at $74.91, give or take, slightly up from prior year conversion factor. And we can see here we also have an estimate of the proposed pass-through spending for drugs, biologicals, and devices of just about $150 million. Similar to inpatient, outpatient has an outlier when those outpatient cases become high cost. This is the calculation of how they arrive at that outlier threshold, and then we have our threshold here of $3,825. So once facilities' calculated case goes over that threshold, there's additional reimbursement available. Something of note, Moss Adams has done quite a bit of work in the area of site-neutral payment. Our partner Cheryl Story is active in this space, and we wanted to include this slide because as folks are reading the OPPS rule on its surface, you have to account for that site-neutral change where there will be a slight bump for the brick-and-mortar hospital services. There's going to be an enhancement on the physician fee schedule side, but overall it's a significant net reduction in money going from the government to the facilities for those new off-campus departments. So something to be aware of. I know there's a lot of law firms and others out there talking about site neutral, so definitely keep that front of mind as we proceed over the next year. Packaged lab services. This was a really hot topic last year. There were facilities who experienced significant reductions in outpatient reimbursement because those lab services that were ordered on the same day by the same ordering physician as the primary service were being packaged with the APC and not paid separately through the laboratory fee schedule. CMS has reversed their position on this. What was really interesting is there was a reduction in some reimbursement, but actually what ended up happening is overall payments on a net basis actually expanded for both lab fee schedule and APC. CMS realized that that may not have worked out so well, and they backtracked on the packaging. This is a slide that details for various states what their overall estimated change in outpatient reimbursement will be from last year to this coming year. As you can see, net positive across most of the states in this region and otherwise, with the highest being in Hawaii, closely followed by Colorado. E&M and other clinic and ED visits, we can see here that on the clinic side of the house, we're now receiving a common payment rate. There continues to be discussion in the rule as to whether or not Type A and Type B EDs should revert over to one payment rate for various CPT levels. They remain to pay separate levels based on acuity for the ED, but they are holding fast on the clinic side. And with that, we will close out with a few comments on the physician fee schedule. These are highlights from the proposed physician fee schedule rule. A couple of things of note, expansion of telehealth services and major changes to provider and supplier requirements for Medicare Part C. We're going to see a lot of discussion in those areas, especially with telehealth coming up. I know a lot of facilities are gearing up to expand those services. And with that, we will get to our last polling question. Emily?
Perfect. Thank you, Paul. And we're squeezing in one more polling question. Did your organization submit comments to CMS on any 2017 proposed rulemaking? Yes, no, or I don't know. And once you've completed all CPE requirements, you will be able to download a PDF of your CPE certificate from the certification icon at the bottom of your screen. And let's see what everyone says.
That's great. Definitely an area of interest for a lot of folks. Obviously, reading through thousands of pages of rulemaking can be fairly mind-numbing, but we definitely encourage facilities, especially those who are active with their local lobbyists and others, as you're interpreting the rules, whether proposed or otherwise, definitely digest that material, send in commentary. It is interesting, in the final rule, Medicare publishes the comments that they received with a response. Not all comments affect change, but it's always important to get your opinion out there so that CMS can take that under consideration. As Emily mentioned, our slides will be available after the presentation, and there are a handful of infographics that you will find at the back of our presentation. I won't go through those at this time, but if you have any questions on those, certainly let us know. I would also like to include some information in our presentation on our upcoming healthcare conference. As most of you are aware, we in the healthcare group do our best to get as much information and content out to the marketplace as possible. So certainly visit our website if you have any questions or would like more information on our healthcare conference. Really appreciate everyone attending today. We had great registration, great attendance on the line from folks from all various types of facilities. And with that, I will hand it back to Emily to finalize the presentation.
Great. Thank you so much, Paul and Glenn, for a great presentation. We covered a lot of material today. We did have some attendee questions come in, and we are out of time to answer those live. However, we'll be happy to follow up with you via email after the presentation. And as a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet in order to receive this credit. And that is available from the slide deck and handouts icon at the bottom of your screen. If you participated as an individual and met all certification requirements, your certificate is available to download now in the CPE icon, also at the bottom of your screen. Open the icon and click the printer in the lower right corner to download a copy. I'll keep the webcast console open for a few minutes to give you time to download your CPE certificate now. A copy will be emailed within 2 weeks should you have any difficulty. And here is a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey as your feedback is very important to us. Thank you for joining us, and we hope you'll join us again next time.